My major area of work is in community-based participatory research. And that's with a mission to involve community partners as colleagues, partners, drivers of the research from their own perspective and knowledge base, and all to improve health and health equity in their own communities. And I act as a supporting partner and a academic who can work with communities who in providing different sets of skills and knowledge to assist them in developing healing practices for their own communities. I actually think community health has to be defined by each community that they work in, but I define it in multi-levels. One is obviously people's own knowledge and practices and understandings of what makes them healthy. But the other, at the very highest level, are the policies and practices and conditions that really support or are barriers to a whole community's health. And these conditions I look at as whether they're equitable or fair for communities or whether they're not. And as we know, we're in a global world of increasing inequities based on all kinds of historical abuses and patterns, and such as discrimination, racism, unfair economic policies that really prejudiced many communities against the possibility of even maintaining their health. So it's both a personal perspective and a community cultural perspective, and then a very high-level policy and economic conditions perspective. And I genuinely believe that if we don't have the economic conditions for fairness to communities, it's very hard for people to maintain and thrive in their own health. So, but people do thrive, people are resilient, communities are resilient, and they manage to find health and healing even in very highly difficult situations. As we know, the US is highly fragmented, and healthcare systems are profit-making fragmented entities. We do have some policies that have tried to provide access to healthcare across the board, but we have very different systems. The Indian Health Service is the most underfunded system in the entire country. I think that next on that would be the prison system is very underfunded for health. So I'm talking healthcare. And of course, the private industry benefits people who can afford the best healthcare in the world. So we have a very fragmented healthcare system with attempts through Obamacare academic institutions trying to provide healthcare to underserved communities. But then health is way, way beyond healthcare. Mm-hmm. So for me, again, it's fragmented and state-based and local-based and tribal-based. And but we have public health systems, some which are very well funded, but as a whole in the last couple decades, our public health system has lost money and to preference the healthcare delivery system. So our public health systems are basically 3% of national GNP in the US, but different states have different manifestations of that and support. With COVID, there's now a flood of money coming into states to improve public health infrastructures. So we will see if that makes a dent in improving our public health system. Yeah. And again, communities have their own systems of health and healing. So you've got these very diverse ways of thinking about community health, from a healthcare delivery system, which is not fair, and a public health infrastructure, which has lost money over the last couple decades, and then communities that have done their best. In New Mexico, we've had kind of different histories, but a good solid history of health councils that have been planning bodies and somewhat service delivery per county. And they've been able actually to do quite a lot, sometimes with funding from the state health department, sometimes with no funding from the health department. But they've managed, many of them, to keep going and be collaborative bodies that have really supported county processes to provide networking, information, support. But the it's not a system that is institutionalized in a strong way that keeps going, but it's very dependent on people's own desire to really have community level input into health systems in their own communities, public health systems, as well as healthcare delivery.
Yep.
So, and public health, of course, is schools, it's education, it's transportation, it's economics, it's health is everything. That's how I think of health. I think of community health as everything, as multi-sector.
Yes.
And if these multi-sectors can work together, you know, I'm a longtime believer in the World Health Organization model of healthy communities and healthy municipalities, which are very much multi-sector driven systems. In New Mexico, our health councils have reflected that, these multi-sector partnerships. Some have had longer ability to stay afloat when the state money ended, some not. We have new tribal health councils that have been given support by the state to really look within tribal health systems. So that's again, it's a fluctuating kind of opportunity, but this approach of healthy communities, healthy municipalities, where communities themselves co-organize, I think is a very powerful one. So I'm a transplant to New Mexico. I arrived here in 1981 and started in the 80s working with tribal communities, and have learned a lot as an outsider working with communities that I honor and respect, but am not part of. And that's been a really phenomenal learning, in that it shows me what I know and can do, and what I have to respect community knowledge to bring to me, so that we can support the appropriate community health programming for any community. So I guess I would say I've learned a lot about humility, that I've learned a lot about listening, that I've learned a lot about engaging in dialogue with community partners, that I've learned a lot about the limits of my knowledge. I mean, I actually have solid academic knowledge about working in strengthening community health. I know about prevention strategies. I know about policies that are necessary. But I think the most important learning is listening.
Yeah.
That I have to really pay attention all the time to maintain that capacity to really support communities to grow their own community health processes and programs and practices. Facilitators are having a team that is an interdisciplinary team that I work with, and I include my community partners as part of that interdisciplinary team. We're all co-researchers, we're all co-producers, we're all co-learners. So that's been a facilitator, being very direct around trying to maintain and support that interdisciplinary and inter-knowledge-based team. Barriers, of course, are funding, are time, are people in communities are not, I do what's called participatory research. So we're trying to generate knowledge at the same time as improve very specific health, community health outcomes, but through a research lens. And community practitioners, they're just doing programs. They're not necessarily thinking of the research questions. So there's been some learnings around that. And of course, just barriers in terms of inequitable policies and inequitable economics and racial discrimination and injustices. All of these huge barriers.
Yes, they are very big.
To changing community health.
Yeah.
But working with tribal partners and Native communities has been respecting and honoring their own systems for tribal programs, and both traditional spiritual systems that I don't have access to, but I know exist, as well as what's within the clinical and public health and education departments. And there, a facilitator is really respecting the role of language and culture for generating positive health outcomes for kids. And so just working within those systems has been really fascinating to me, and I've learned a lot. about those facilitators, or the importance of identity and strength based on family and strength based on communities. Close their borders and still have their borders closed as a protective device. And the tribes have done very, very, very well in terms of vaccine uptake. They've mandated it. They've said you cannot leave the borders of the reservation unless you're vaccinated. So they have 80% vaccination rates compared to a lot of these governments. New Mexico has done very well. New Mexico has done well in vaccine uptake, 60%, but it's highly diverse by different subpopulations. Our 18 to 24-year-olds, who are all going to be going back to college right now, are only a third vaccinated. So what are we doing with open policies when only a third of this age group are vaccinated? Is very scary. So I think COVID's impacted the work because we can't go out to our communities. We're just used to going out. We're used to doing the work in community settings, and we've been stopped for a year and a half. So we've tried to stay connected with text, phone, Zoom, however way we can. But at the same time, we've tried to provide services. We've tried to provide hygiene products. We've tried to provide information of how people can get access to treatment. We've done all these kind of support services. A lot of our tribal partners who were working with us on programs moved to food survival. That's what they were doing. They were just providing food to their communities. So, now we're moving in a different direction. The question is, how is the vaccine going to protect us, and how are all of the opening up policies going to be still difficult and harmful potentially, with the Delta variant especially. So I know we're in a mid stage of the COVID dynamic, and communities have shown they can survive. And in our communities, we've seen a lot of GoFundMe, very individual. Do you know that word, GoFundMe efforts? It's where people themselves create fundraising efforts online for their communities that they get out through the social media. We've just seen, and a lot of people have come together around supporting each other, nonprofits, but also these individual GoFundMe, social media driven fundraising for supplies, for transportation, for isolation hotels. Our city of Albuquerque did very, very well, for example, with the homeless population, opened up all the hotels that they could for people in isolation who needed to be quarantined. So you've had a lot of local responses. Start with the key importance of listening to communities and listening to what works for them and listening to what are their barriers and concerns and fears and distrust. There's a lot of distrust around COVID, again, through multiple reasons in our country, in terms of COVID response and vaccine uptake. And so I think this epidemic is going to be with us for years still. It might become endemic in certain places and manageable in other places. It's going to flare up, but we will have other infectious disease epidemics that come our way. So we always have to listen and try and understand how to build trust and how to build practices that are supported by communities, that are healing and community health practices. So listening, engaging in dialogue, and trying to build the actions based on what we hear, I think is the most important message I have. I mean, there's still chronic disease with us. There's still food insecurity. There's still huge, huge health issues globally, whether they're chronic disease, cardiovascular, or whether they're infectious. And I think we have to be responsive to what's happening acutely, but also think long-term. So I would encourage the new community health professionals coming in to think both responsively on an acute basis, but building strategically an infrastructure in the long term that can support communities to engage in their own health. I mean, I think we have to give it to the communities and create the public health structures and economic structures that support that.